Greetings, class. This lecture will be part one of Study Validity and Bias in Research. We're going to look at an introduction to the search for truth through research, and we are going to talk about sampling and sampling bias. Study validity is how accurate is the study? Does it truly represent truth in the sample? Does the sample correspond to your patients or population, and therefore to whom can the results be generalized? When we look at study validity, we're going to look at two areas. One is internal validity, one is external validity. Internal validity is how well do the results represent the truth accurately to the sample that was studied. External validity is going to be how well do these subjects represent the patient or populations for which the results are going to be applied. That is the generalization. How do you take the sample and then generalize the results to a population? First, we need to look at the difference between validity and reliability, as in many cases these terms are used interchangeably. One would think that if you have a reliable study or a reliable measure, then your validity would be accurate as well, but that is not what the two terms mean. As I just described, validity is how accurate are the results, is what was measured what the researcher thought she was measuring. Reliability, on the other hand, is really repeatability. Do you get the same result when you do the measure over and over again, regardless of whether it is really accurate? So we're going to use a lesson from photography. The scene that I took a picture of at one of my favorite ski areas, Mount Van Hoevenberg, the Olympic Sports Complex, cross-country ski complex in Lake Placid, New York, is shown on the left. This is the Brookside Trail, named aptly for said brook, and a nice big rock there in the middle with lots of new fresh powder on it. That is what the scene actually looked like. The photograph on the right, a high contrast picture of the same scene. So when we look here, the photo on the left was processed at a certain photography venue, and it came out a little lighter than what the actual scene was from that day. And the picture on the right was processed by a different processor. Let's call it processor Y. Came out exactly the same as before. Then we took it back to processor X, and we got the print remade, and it ended up darker than before. And processor Y did exactly the same thing. Now this example is really back in the days of film black and white processing, where you would have differences in results. You can simulate the same digitally, which is what I did here. But with digital photography, of course, you can control your contrast and brightness right on the screen. But for the sake of illustration here, processor X produces three images which are fairly representative of the scene. Just one is exactly right, the other is a little too light, and the other is a little too dark. But when you look at each one of them, it looks more like the actual brook scene than the picture processed by processor Y. However, processor Y, despite not being accurate, has produced three images exactly the same. And so they are repeatable or reliable. So you can see how you can have a study that is valid but not reliable, or you can have a measurement instrument that is valid but not reliable, or a screening test which is valid but not reliable. And likely you can have one that is extremely reliable but not valid, not accurate to the actual measure. So both of these can be measured statistically by comparing the study results to the accepted standards. And examples of these would include measures of blood pressure with a sphygmometer or intraocular pressure with a tonometer. My theme for the course is that research is the search for truth. So you have on the left your actual status of somebody's health or status of the effectiveness of a treatment. That is the truth. To measure that, you take a sample of subjects, which hopefully will represent the people that you want to apply the results from. You're going to take measures, you're going to make comparisons statistically, and then you're going to apply the results. But there are barriers to the truth in research. The first would be sampling bias. If you are looking for measuring blood pressure in a group of inner city people and you use a sample of suburbanites, then you have not measured the group that you want to apply the results to, and this would be called sampling bias. Likewise, if you wanted to apply results to children but have only investigated adults, you have a sampling bias. Next, you actually have the measurements. Errors in measurements, such as a sphygmometer that is inaccurate, either too high, too low, or random, is called misclassification, or information bias, or measurement bias. And in part 2, we will talk about the different types of misclassification, primarily random and differential. Well, if we got an accurate sample and we made correct, valid measures and reliable measures, then we are going to try to make comparisons. If there are variables involved that confound each other or interact, then this will lead to another barrier to the truth. A confounding variable, which you will hear several times throughout our courses with me, is one that is an independent risk factor for the outcome and is associated with the exposure. The easy example we looked at with myopia back in our cause and effect lecture is that myopia is associated with intelligence, it is associated with knowledge, it is associated with socioeconomic status, and it is associated with race. So whenever we are trying to find a cause and effect of myopia, whether it be genetic, environmental, behavioral, these other confounding variables will mask possibly the truth. And finally, of course, the generalizability. If we do not have the appropriate sample or the appropriate measures or control for confounding, it is difficult to generalize the results from the sample towards another population. So in research design, step 1 is to define the problem or clinical question, and step 2 is to define the target population. Step 2 is the one that is most often ignored by researchers, and that's when they get in trouble later on trying to generalize or apply the results in clinical practice or in public health practice. So we are going to spend a little time now talking about sampling or selection of subjects. Sampling bias is also known as selection bias. And the big question is that whenever you read any research study, does the sample represent the target population? Oftentimes studies are done in hospitals. So those subjects may not be as healthy as subjects that are outpatient or healthy subjects that don't need medical care. So we can't make a generalized statement on results from a group of hospital patients to ones that are not hospital patients. I'm going to use one of my favorite trees from down the road that just happens to change colors at a different rate between certain branches, as well as it just plain being kind of pretty. So let's suppose our task is that we want to sample leaves from this tree. There are many ways we could do this. We could take a consecutive sample. For example, we could just take a line across the tree horizontally and take every leaf across left to right. Would this result in a representative sample of color of leaves on this tree? The horizontal bar clearly would not, because it's going through the area of the tree that is essentially all green. Another option would be take a vertical consecutive sample. This might give a more representative view because we are hitting both the orange parts of the tree and the green parts of the tree. But is it accurate to the actual proportion of green versus orange? Probably not, because I haven't even showed you the upper part of the tree, which happens to be all green as well. So the vertical consecutive sample here would probably overestimate the amount of orange or red leaves. So if you set either of these bars arbitrarily, the result will not be intentionally biased. You didn't mean to go out and take the wrong sample, but because of the fact that the branches are not random in their change in color, your sample will not be accurate. So what is the perfect way to get sampling bias? In this case would be to just have a short person pick 50 leaves, and they would probably get almost all orange or red leaves. Especially if they can't even reach the bottom branch, they would only pick up the ones that had fallen on the ground, which are going to be the ones that are dead and fall off. The green ones aren't going to fall off. So that's an example of the perfect way to get sampling bias. So what are some other sampling methods? Well, as I just suggested, if we wait for them all to fall off, they're all going to be orange by that time, and we're not going to have a representative sample of this particular time that we are looking at. So sampling bias can occur by the time that the sample is taken. So let's try to do some random sampling. Well, one way to help with randomness is to actually use a grid across the tree and select a certain number of leaves from each section of that grid. This would actually be called stratified random sampling, since we are going to randomly take a certain number of leaves from each strata or each section. As you may infer, if we make smaller and smaller grid sizes, we will get a more representative sample. Sampling for descriptive studies involves defining the target population. So for the United States Census, for example, the target population is all residents living in household units in the United States and Puerto Rico. Whereas the National Health and Nutrition Evaluation Survey is target population are adults and children of the United States, not necessarily related to their household units, simply the total number of people. And compared to a very famous cohort study, the Nurses' Health Study, the original study was intended to look at female nurses of age 30 to 55 in 11 of the most populous states. It was not intended to be a random sample of the entire United States population. Regardless, we start by defining that population. Then we define the questions of interest. In the U.S. Census, the question of interest is race, gender, age, income, job, education, primarily socioeconomic data. Whereas the NHANES study's primary questions of interest are what are health behaviors, diet, and the chronic diseases. The original Nurses' Health Study had one primary outcome, and that was to find out if oral contraceptives increase or decrease risk of cancer in women. Now, since that time, the study has been expanded to look at many secondary objectives, and they have added additional measures. They've expanded their samples. So that has changed over time and provides us with a wealth of health information in addition to that one primary outcome that they were looking at. And in case you wanted to know what the answer is, there is a slight increase in risk of certain cancers in women of that age group who used oral contraceptives long term. But at the same time, there was a decrease in heart disease for those subjects. So you have here our two leading killers of the population, and the use of oral contraception increased the risk of one of them slightly and decreased the risk of the other slightly. And so this is why oral contraceptives or birth control pills are certainly not banned from the market, but are simply a decision to be made between the prescriber and the patient. Once selection or sampling bias is in a study, there isn't much you can do to save it. Other types of bias, confounding, measurement bias, reliability issues, validity issues, these things can be somewhat controlled and estimated and measured for in a research project. But sampling bias, there is no way to make an estimate on a population that you never studied. So this is why I go over sampling bias initially, and the reason for defining your target population as your second most important question, because that is the only way you can assess for your sampling and to avoid the sampling error. And that is the end of part 1 for